Yeah, yeah, absolutely. Okay, bye-bye. Bye. I gotta get mic'd up. Mic'd up. We okay in the back? We good? 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 Yeah? Okay, great. So it looks to me like the brunt of the class actually doesn't come to class. They basically watch the lectures online. I'm thinking I'm going to write every other class two final exam questions here that only the people in the class will see. Would that get me in trouble with the campus? I don't know. What do you think? No? Yeah. I might do that. I did it at the med school, but I'll keep you posted on that. Okay, so a couple things. I got called yesterday morning by a colleague because one of his friends was visiting town and had an episode, and this is a woman who had a lumpectomy for breast cancer about 10 years ago. And she was outside in the yard, and she started getting some kind of strange visual illusion, and then she started getting a repeat, like the scene just kept repeating in front of her. And that's the last thing she remembered. And then when they went outside, she was having a generalized seizure. So who wants to tell me what's going on with her? Anybody want to take a whack at what's going on with this lady? What do you think's happened? Yeah, please. Okay, so basically she had some visual aura, some perceptual visual changes in the environment, and then the scene that she was in seemed to keep popping back in her mind, almost like a replay of a scene. And that's the last thing she remembered. They found her in the backyard having a generalized tonic-clonic seizure. Got it? Okay, so what's going on? Well, she's definitely having epilepsy. I just told you she's having a tonic-clonic seizure. All right, we're going to keep you out of the emergency room. You're fine. You're good. Yeah.
She had a seizure that started in the visual cortex and moved to the hippocampus.
Could be either visual cortex or because of this repeat of the environment, this kind of I've been here, deja vu. Could also be in the temporal lobe. I don't know which it is, but she definitely had a focal onset somewhere, and she's being worked up. Hopefully it's not a breast metastasis, so we'll see. But anyway, you can see these are real-world things that happen pretty much all the time. So I wanted to finish the epilepsy talk. I didn't get to this last slide, and this has something to do with public health issues. It turns out in large parts of the world where there's a high water table and you have a disease called cysticercosis, tinea solium. It's a tapeworm infection, and you get it from eating uncooked or poorly cooked pork. And if this was a pig, and you actually cut through the tissue, you'd see a cyst like this. And you see that little thing inside the cyst? That's actually a worm head. So if you eat infected pork, that cyst opens up. Pradeep, later I'm in class. I got to go. I can't. Bye. Is that okay? He wanted to sign up for B course. No, just kidding. This thing breaks down, attaches to your small intestine, and grows to about 25 feet long. And then it sheds eggs. If the eggs get in the water table and you ingest them, the eggs in your stomach go into a larval form. They bore through your stomach lining, and they go to your brain. And you'd say, that can't happen here. Well, I can tell you I've seen well over 100 cases at Highland Hospital because these are people coming in from Central America, Mexico, and South America. It's a huge cause of seizures in that population. My rough estimate of the number of people in California with this problem are 60,000. You never hear about it, right, because it's in immigrants. I shouldn't make any judgments, but I just wanted you to be aware of this. This is actually a human postmortem brain. That's normal brain tissue, and there's a cyst sitting there in the cortex of this person's brain. Now, if you get them early, you can treat them with anti-worm drugs, but I just want you to be aware of it, that There's a big spectrum of things that can cause seizures, again, based on where you're from, how old you are, genetic, non-genetic, in this case, infectious. Maybe the lady that I just told you about, maybe it's recurrent tumor. That's your job, is to figure out which it is. Okay, so we're going to do a complete flip today to movement disorders, a huge problem. And again, we've been doing this since the beginning of the class, so let's do it again. Who knows somebody in the family or close relative or someone close family friend who has Parkinson's disease? Take a look around the room. 1, 2, 3, 4, 5, 6, 7, 8. Looks like it's about maybe 15, 20% of the room. Would someone mind telling me what they notice in their family member? Did you raise your hand? Who raised their hand? Did you? What happened? What's going on with them? What do you observe?
My grandmother had Parkinson's. And there's definitely like noticeable changes in movement where he'll there's sometimes where he's not moving as much, and like the tremor with his hands is pretty common. Also, sometimes he'll sort of just like stop and look at you, and it'll take him a really long time to respond. To
get started. He has he freezes.
Yeah.
So he has slowness of movements, a tremor, and he freezes.
Yeah.
Right? Okay. So those are kind of classic symptomatology of Parkinson's disease, and we're going to talk about that in some detail. We're going to split movement disorders into two kinds of movements. Either you move too much, you move too little, your grandfather, Parkinson's disease, or you move too much, Huntington's disease, hemibolismus, and we'll get to what those mean. So either don't move or you move a lot, and that's the big dividing point. So Parkinson's disease, described in 1817, long time ago, by Parkinson's, it was found to be loss of cells in an area of the brain called the substantia nigra, and I'll show you a picture. And then in 1960, the big breakthrough came when people found that there was a decrease in the basal ganglia parts of your brain of dopamine, a neurotransmitter that, as you'll see, is actually made in the substantia nigra and transported to the striatum. And this is the fundamental pathology in Parkinson's disease. There's your substantia nigra. This is a nice cut, axial cut through the brain. Here's your brain stem. And see that dark area there? Those are pigmented cells in the substantia nigra. Now, it's a little bit off-slice, the cut, so you don't see them quite as well on the other side. In Parkinson's disease, here's a normal substantia nigra, nice and dark, filled with dopamine cells that are going to allow to get transported to your striatum and to your frontal lobe so you can think clearly and you can move more effectively. And this is Parkinson's disease. And like many important discoveries, a pathologist simply noticed post-mortem that the Parkinson patient substantia nigra in the midbrain was depigmented. Basically, it was not dark. And this really honed, basically, research on the function of the substantia nigra. Now, the pathway is called the substantia nigra in the brainstem, striatal pathway. In other words, it's going from the midbrain and it's taking dopamine up to the caudate and putamen and globus pallidus, the striatum, and there's multiple kinds of dopamine receptors. And this particular one for Parkinson's is D2, a D2 dopamine receptor, and this is what deteriorates. Now, if I do a PET scan and I take, quote, normal people, and I tag the PET, I have a tracer that basically attaches to dopamine, and I look at 30-year-olds, actually you guys would be really over here, but 30-year-olds, that's nice, big, bright uptake of dopamine in your basal ganglia. That's normal. You can see by 70, it's just dropped off a little bit. It's maybe down 50, 60% compared to its peak here. If you get down to just 25% of dopamine, just 25%, you get Parkinsonian. So what this is telling you is most people, by the time they're 70, have a substantial decrease in their dopamine already. They're on the edge. They don't want to lose any more, because if they lose any more, they're going to tip into the clinical syndrome of Parkinson's disease. So the epidemiology is really, really interesting in Parkinson's disease because it's called a disease, but it's really a syndrome. There are many, many, many causes of Parkinson's disease, and I'll go through them for you because they're quite interesting and quite important. The number of cases is now staggering. 40 to 70 progresses over 10 to 20 years, 20 new patients per 100,000 per year, a minimum of 1 to 3 million cases in the United States. And there will be more. Again, remember this thing about if you're living longer because you get better treatment of your diabetes or your hypertension or your cholesterol or your cancer or any of those things, you now become more likely to have a neurodegenerative problem like we talked about, Alzheimer's disease, frontal temporal dementia, and now we're talking about Parkinson's disease, the shaking palsy. So, what are some of the causes? One of the most important ones is manganese intoxication. And you might say, manganese, what is that about? Well, it turns out that manganese is a heavy metal. It's a specific toxin to the substantia nigra. And you say, well, how do we know that? Well, it turns out that manganese minors have a huge incidence of early onset Parkinson's disease. And in fact, when we first started to use drugs to try to treat, to replace the loss of the dopamine in the Parkinson patient's brain, they were tested on Chilean manganese workers because they had such a high incidence of very severe early onset Parkinson's. By the way, you can get it from other things, manganese. You guys have been to, craft festivals. When you see some of the pottery with the beautiful bright blue glaze on it, that's manganese. Now, if it's glazed properly, you're okay. But every year, about 1 to 2 young potters end up with Parkinson's because they're not handling the manganese. Now, you'd say, the other thing that's important about this is we've now found, we found that welders, right? Welders have a higher incidence of early onset Parkinson's because they're exposed more to manganese. This was a very interesting study in a Parkinson clinic from Washington University Med School where they found that the average onset of Parkinson's in their cohort, a huge cohort, was in the early 60s. What age did your grandfather start at? Yeah. He was much older, yeah. So the average age is about 62, 63. The welders were onsetting in their late 40s. Okay, big epidemiology. Drugs, neuroleptics, these anti-dopamine drugs that are used to treat psychiatric disorders. Dementia pugilistica, which is repeated head trauma. And I think you all, for those of you who know anything about sports, remember Muhammad Ali, the famous Cassius Clay, the famous boxer with severe Parkinson's. He got that because of repeated head blows and damage to his substantia nigra. So that's called dementia pugilistica. Occasionally, multiple cerebral infarcts can look like they have a Parkinson's syndrome because they actually have infarctions that knock out the striatum. So there's nothing for the dopamine to work on. And then finally, the big cause in this country, the one that was the swine flu epidemic in 1916. And you say, why does that matter? Because that's why they're so freaked out about recurrent influenza epidemics. This particularly swine flu epidemic was toxic to the basal ganglia. The estimated number of people who died from this flu from getting brain damage was 50 million, and roughly 50 million people were left with Parkinson's disease. Okay, so this was a viral infection of the brain, just like you can get other viral infections that target one area of the brain, like basically polio. It gets your motor neurons, etc. So, of course, we don't have any more cases of this. All these patients have basically died, but it was a huge cause of a very severe abrupt onset Parkinson's. Now, what are the clinical features of Parkinson's? Bradykinesia, we already heard that. The grandfather was slow. Cogwheel rigidity. When I feel the patient's tone, I actually feel a ratchet in their muscles, in their joints. It's very, very characteristic. Loss of writing reflexes. If you remember the exam when I pushed Devin and she didn't fall over, remember and then another time she fell over. That was loss of her balance or her writing reflex. So balance is off. You're slow. It's like you're in a glue factory, and you have a resting tremor. at about 3 hertz, or 3 tremors per second. So these are the characteristic features. They're very easy to see these patients. There's a lot of people walking around in the shopping mall who actually have Parkinson's and don't know it yet because they haven't developed a tremor. And a lot of times people just think, grandma, grandpa's getting slow, when in fact, if they're walking like this and everybody else is walking in a pretty good pace, they've probably got early Parkinson's, which would be a good time for them to know about it and get treated and maybe even try some neuroprotective drugs. The patient has decreased facial expression, so they have a kind of flat face that doesn't show expression. They basically have decreased blinking. They have decreased arm swing. Here's how the normal arm swing, right? So the Parkinson patient is walking with decreased arm swing with small steps, decreased arm swing, decreased hand gestures, and hypophonic speech. What does hypophonic speech mean? It means the Parkinson patient tends to talk at a low volume, basically. Hypophonic speech. Patient also has micrographia. What does that mean? Micrographia is a characteristic feature of the patient with Parkinson's disease. So if I were going to ask the patient to write a sentence, today is a sunny day. You see what I just did here? As I wrote the sentence, it got smaller and smaller and smaller and smaller. That's a characteristic feature of the writing. Micrographia. Freezing, which basically you often see as people walk through doorways. Let's say the doorway's right there. The patient will be walking along, they'll get to the door, and they won't be able to get through. They'll freeze. Cognitive is initially intact, but as the disease progresses, there's another projection, a dopamine projection to the frontal cortex, not the basal ganglion movement, but to the frontal cortex, that part of your brain absolutely critical for executive function, thinking, planning, organizing, etc. So they will eventually start getting frontal lobe symptomatology, and this is the D1 receptor. So the D2 receptor is the basal ganglia movement. The D1 receptor is frontal cortex, thinking and planning. And of course, I've shown you this, stoop posture, forward, etc. Instability, very, very common. The patient can fall, and falls are a bad thing in older people. They're a huge cause of death and disability. In fact, a 97-year-old, I won't go into the details, she tripped in her bathroom 11 days ago. She was totally with it. She got knocked out transiently. She came to. She talked to the nurses in the extended care facility, and then over the next 2 hours, she slipped into a coma. Okay, now we haven't really talked about trauma yet, but that's a garden variety scenario of having a head injury and then getting a big clot between your brain and your skull, a subdural hematoma. Cut to the chase. They did emergency surgery. I'm not sure they probably should have. They didn't really want to, but the family was pushing for it. She remained on a ventilator for 10 days, and then they disconnected her, and she died. So falls are bad, and they're even worse in people who have balance instability. So here's a Parkinson patient walking, just to give you a feel. Having a lot of trouble getting up out of the chair.
Okay. Now walk arms. Towards the wall.
March up petit pas, small steps. Punched over, no arm swing, absolutely classic Parkinson's. What I like to do with the patients is I have them sit in a chair and I have them cross their arms. A normal person, you say get out of the chair, you can't use your hands to basically push on the chair. A normal person would just get up. A Parkinson patient has a great amount of time because they have trouble controlling their axial core, like that gentleman. He had to rock a few times before he finally got out of the chair. So here's someone freezing. Just froze. Just frozen in place. Interestingly, sometimes these patients going again. sometimes these patients, if you give them a laser pointer and they're frozen and they put the laser pointer in front of them and point it on, on the floor, they can unfreeze and follow the laser pointer. Kind of amazing. It's a very interesting problem because before the advent of L-DOPA, people were frozen in nursing homes, right? And the lore was if you yelled fire, these persons who were end-stage Parkinson's would get up and run out of the hospital and then freeze again. You'd say, what is going on, right? And it's just a phenomena that happens. And when I'm examining patients and they're really slow, and I say, Mr. Smith, reach up for the keys. And they go, the keys are... I tell them, Mr. Smith, reach up for the keys. And it'll go like, accurate, no cerebellar problems, okay? Then I just, without asking him to do anything, I throw them in front of him and he grabs them, right? That's getting up and running out. So the involuntary movement is accessible, but the voluntary control is not. Very interesting in how you're organized as a person to control your movements. Okay, so that was freezing. Here's the 3 hertz tremor that this student's grandfather has, very characteristic.
Or if the medication helped the tremor.
It's a very severe one.
Is that correct?
That is correct.
What bothers you most about the Parkinson's disease?
And when the patient raises their hands, if he would, the tremor would go away. So it's a tremor at rest, not on intention. Okay, very characteristic again, 3 hertz tremor. And then you can see the slow. This person is worse on one side than the other, and just watch his finger tapping. You'll just see that one hand is much slower tapping than the other one. And this is someone who's got mostly lateralized Parkinson's. You can see he's got a pretty rapid tapping speed here, and he's slower here. Really very simple. This kind of bradykinesia, this slowness of movement. And patients can't stand being frozen. It's one of the worst feelings, I think. So, Parkinson patients are the patients who will probably take the most structured medication dosing that you could imagine, because I've had people that I had to have them on 6 to 7 pills a day spread out every hour and a half to get them controlled, and they'll do it. And you'll often see, Michael J. Fox. Michael J. Fox, the movie, the TV star, he's got severe Parkinson's. And if you see him interviewed, he's always moving a little bit. He's moving a little bit because he wants himself to be fully, heavily medicated because he doesn't want to be frozen. And I'll show you what that means, because if you get too much of your medication, your dopamine medication, you go from frozen to normal, and then if you get too high, you basically start getting excess choreiform movement. So this is an important principle in general for treating people for anything. It doesn't matter. In this case, it's Parkinson's. This is your, basically your drug level in your blood, and let's say it's the amount of dopamine. If you're here, you're going to be symptomatic, and if I treat you, this is the therapeutic window. I want you right here after I give you the pill. I want it to be right there, and then I'll give another pill. That will be the dream, right? I've kept the patient in the perfect therapeutic window for his entire treatment period. But if they get too much medication, they're like this. And when they get up here, they go from being not moving to excess movement. Okay? They become hyperkinetic just based on the medication. Okay. So before I show you a little bit more about these disorders, I want to tell you about another tremor disorder that people often confuse with Parkinson's, but it's not even close to Parkinson's. This is what's called essential tremor. Has anybody seen anybody that when they reach to do something, they get a fine tremor? I don't know if you see, right? Okay, that's called an essential tremor. And it's about 30 to 40% autosomal dominant in a family. You all have a tremor. Everybody in this room has a resting tremor at about 10 hertz. Does anybody have can I have a piece of blank paper? please. Can I use your hand? I need you to come up here. Just put your hand out. Okay, spread your fingers out. And if you look really closely, see what he's got? Teeny, 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 teeny tremor. That's normal, right? That's because you can't even see it, but when I put the paper on, it picks out the amplitude of it a little bit. You're all having that tremor because it's telling you where your body is. You're getting proprioceptive feedback, and it's normal. And, if you're scared, you've seen where your excess catecholamine, like you're hyperthyroid or something, you'll see you get that tremor. Have you ever seen anybody get a tremor when they're scared? Basically, that's basically what it is. It's an exacerbation of your normal baseline tremor. But there's a disorder called essential tremor that, in fact, you get a tremor not at rest at 3 hertz. You get an exacerbation of your physiological tremor at 8 to 10 hertz. And it looks like this. And it's an interesting one because it is treatable with various medications. So in the clinic, I had people draw circles, and that looks good. And here's the patient. You can see they got this tremor. And I can actually, as I see them in the clinic come back, I can just have them draw the circles again. And I can actually grade how much the medication is helping their tremor. So this is another one to think about. But they have no other symptoms of Parkinson's. They're not slow. They're not hypertonic. Their tone's not increased. They don't have any of those other symptoms. And because it's not a progressive fatal problem, we actually don't know what the actual underlying neurobiology of it is. But it is not. How many people know somebody? Let's just see. So 1, 2, 3, 4. So 4 people in this room know somebody with that particular syndrome, essential tremor. Now, the treatment is L-DOPA, and, it's quite effective. You're kind of you're giving the person L-DOPA. It's picked up by the substantia nigra. It's converted to dopamine. It gets transported up to the striatum, and you get, in about 85% of people, a really nice treatment efficacy. We came up with things to decrease the side effects of the medications, so that we could, it used to be that you'd give the dose, you'd have to give a high dose to get into the brain, and there'd be a lot of symptomatic body problems, GI problems, etc. And then we figured out a way to decrease the dose of L-DOPA and decrease the side effects. So you get what's called you get the L-DOPA along with the dopa decarboxylase drug. And we get really pretty nice response. We started with presynaptic drugs, which are being picked up by the substantia nigra, and they'll produce L-DOPA to dopamine. It gets transported from the substantia nigra up to the striatum, and it's released, and basically you get a nice therapeutic response. Now, the problem with this treatment, and it's very effective, it's actually quite effective, is that eventually patients lose their substantia nigra cells, so they don't have anything to convert the L-DOPA to dopamine. Now they got a problem, right? So what were developed in the late 1990s were postsynaptic drugs, the drugs that you give that forget about being picked up by the substantia nigra, which is gone. It actually, they directly attach to the postsynaptic membrane, and it's another nice treatment approach that we have. So we have presynaptic, postsynaptic drugs. I'd say about 85% of the patients were able to get pretty good control. And I will tell you this, if you look at the pathology of the brain, when the patient dies, you don't see evidence of a viral infection. You just see nonspecific changes. So the actual cause of modern-day Parkinson's, we don't know. We do know one little clinical epidemiological vignette, and that is that it's higher in farming communities, which have a higher exposure to organophosphates. Now, we don't have a direct biological link, but we epidemiologically know that. The other thing we know, and I find this to be perhaps the most fascinating, here's a disease that you'd think would have been written about in 300 BC, right? 300 BC, we knew about stroke, we knew about seizures, we knew about all it because they're obvious, you can see them. Parkinson's disease, shuffling, tremor, that's pretty easy to spot. You'll be able to see these patients in the shopping mall. It doesn't appear in the literature till the industrial age. It's not there. That means something happened in the industrial age with something related to our exposure that's being generated by the industrial age. What it is, I don't think has been precisely clarified, but I want you to think about that a little bit. Wasn't in the literature until the industrial age. This major, major worldwide syndrome. Now, I said if you get too much dopamine, you go from not moving to excessive movements. And let's just take a look at this gentleman. It's very massive.
It lasts for about 3 or 4 hours. And then the first 6 months of taking it, I was in very bad shape. I would throw up constantly, and I got dizzy very easily.
From the side effects.
Yeah.
So he's getting a relief. He's not frozen, but he's hyperkinetic. Remember this one right here? He's up there, right? We're having trouble adjusting his dosage. So you can see, you'll see, if next time you see Michael J. Fox, you'll see him moving a little bit like this. That's because he doesn't want to be on TV and freeze. He'd rather be if you ask the patient, they'd rather be this kinetic and moving than being frozen. People can't stand being frozen. It is a very unpleasant sensation. So there's surgical treatments for this, for the patients who fail medication, which most people eventually do probably by 7, 8, or 9, or 10 years into the medical treatment of the disease for a variety of reasons. And there's certain surgical ablations. I've already shown you, I think, earlier in the course, the deep brain stimulation by putting electrodes into the subthalamic nucleus. My colleague Phil Starr over at UCSF does lots of these procedures. They're highly effective treatment. And I've already shown you that picture, so I'm not going to. Remember the movie with the lady who was on and off medications that we looked at earlier in the course? So that's a highly effective treatment. You're shutting off a small nucleus in the brain that actually that inhibits your motor system. It turns your motor system off and freezes you. And now I shut that off with deep brain stimulation, and your motor system is unfrozen. It's really quite remarkable, and it's a nice example of people, basic science and clinical science coming together with an engineering solution to a really common and very important disorder. So how did people think about putting electrodes in the subthalamic nucleus of Lewis? This is a teeny little nucleus, right? I mean, this thing is a small nucleus. We know about it because of hemibolismus. What is hemibolismus? Hemibolismus is a disorder where you get a small 3-4 millimeter stroke in the subthalamic nucleus of Lewis, and the contralateral body part starts flinging. You get flinging movements, excess movements, right? So people said, there must be something about this nucleus that's producing inhibitory tone, because when we lose this little nucleus, the contralateral body is flinging, right? It can happen at any age. I've seen people in their 20s with it. Severe contralateral flinging movements, it's always basically due to stroke. And let me just show you an example of this so you can see. This is a lady who unfortunately had a small stroke. You'll see her left side has these kind of hemibolistic movements.
And then put your arms out in front of you.
Flinging movements of her left arm and left
And
leg
down
so
again.
big that they're actually rocking her whole body.
And try with the left hand.
Cerebellar's pretty good on that side. It's hard for her to even do it on that side. She has such discontrol of movements. It looks cerebellar, but it's really because her arm's constantly basically flinging. You can see it moving. These excess movements
again.
on one side of the body. This focused people on this brain area and has led to the treatments that we now have for people with Parkinson's disease, hemibolismus. Oh, I do have it in here. Sorry. So again, based on the hemibolismus patients and then the basic scientists focusing on the physiology, it became clear that this was a key nucleus for inhibiting the motor system, and that led to the development of deep brain stimulation, which we've talked about briefly before, really early in the course. And basically, you put an electrode into the subthalamic nucleus under stereotactic control. So here's 2 electrodes that have been inserted right there. You can see it here. And they come out. They're externalized, basically. And then you can control them with a battery on your belt. And basically what you do is you put high-frequency electrical discharges into this tip of this electrode, and what it does, it shuts off the nucleus. There's so much chaotic electrical firing, the nucleus shuts off, the patient walks better. It's really quite remarkable how it all comes together. So here is this video again of a lady off without a stimulator. You can see she's slow. She has no arm swing. She's got a 3 hertz tremor. Her face is masked. Watch her turn on block. On block. So you turn like a stiff block. Classic Parkinson's 3 hertz tremor. There she goes back. And she's not responding to medications. So then she's an appropriate candidate for the procedure. She would get electrodes inserted that would be used in, they call it a stimulator, but it's actually turning off a brain area. It's a misnomer. Here she is after her stimulator on. She's much more fluid. Notice her arm swing. Notice her tremor's gone. Notice how much briskly she walks. She turns much nicer, and she heads on back. So this is a very effective treatment. And it's a nice convergence of basic neurophysiology, engineering, neurosurgery, etc. And there'd be much more of this coming down the pike. Right now, the patient has to turn their stimulator on to adjust, it's called a stimulator again, to shut off their subthalamic nucleus. We now have some closed-loop systems where we're actually recording from motor cortex, and this is work that's being done in Phil Starr's lab at UCSF and 4 other medical centers, where the patient doesn't adjust anything. We can get a read of their motor cortex function and turn on or turn off the deep brain device, basically. So really nice to get it. The patient doesn't have to do anything. They can just let the machine control their motor system tone. So pallidotomy is another procedure, and I'm not going to really go into it. It's an attempt to get at this changes in excitatory and inhibitory balance. And again, we go in, and I don't want you to have to remember any of this. I just want it to be in the presentation. So for those of you who go back to look at this when you're doing your whatever and you want to remember about this, this is another surgical procedure. The more common one is really inserting of the deep brain device into the subthalamic nucleus of Lewy. But there's another surgical approach. There's actually even a third surgical approach for people who have predominantly just tremor. Okay, now let's go to hyperkinetic disorders. We just did hypokinetic. I hope you have a good feel for it. Most of the cases now we don't know the cause, and there's lots of people susceptible to this around the world. If you live long enough, you're susceptible. Now we're going to go to the hyperkinetic disorder. I already showed you one, which is the flinging of hemibolismus, which led to this engineering solution or treatment for Parkinson's disease, non-responsive or burning out in responsivity to medications. And this is Huntington's disease. It onsets pretty early, around 40 years of age. It's autosomal dominant. I've actually seen unfortunate, kids, relative kids onsetting in the 20s where they have the gene in the family. So it's autosomal dominant. So if you get that gene from one of your parents, you've got the disease. And this is a very tough disease to have, basically. It progresses over 10 to 15 years. It's much less common, thank God, than Parkinson's disease. But as a neurologist, you see it, and I want to point out to you this idea of commonness and statistics and all the stuff you learn about in all your courses. It doesn't matter if you're the one person with the problem. Statistics are out the window. So you need to really be, if you've got the disease, it's the most common thing on the planet Earth. So you got to be a little bit careful about how you think about some of these disorders. Much less common than Parkinson's disease. Autosomal dominant inheritance. Clinical features. Depression and mood swings. Because not only does part of their basal ganglia fall apart, in particular their caudate nucleus. The caudate nucleus also has massive projections to the frontal lobe. So the patients develop not only a hyperkinetic jerking disorder, and when you see the movies, you'll get it, rapidly what's going on. They also start to develop cognitive changes and become dysexecutive. They're almost like the bad Parkinson patient who loses frontal lobe function, so does the patients with Huntington's. But it's not the primary movement part of the disease. Abnormal movements, involuntary movements of the face, neck, and limbs, and I'll show you movies. It's quite easy to see in these patients. Sometimes this is a choreiform movement, right? It's a jerk. This is an asymptotic movement. It's a writhing, okay? So writhing versus jerking, they can have both, basically. And I'll just tell you that, it is autosomal dominant, and I had a family that I saw. So you can do who's taken, you guys know genetics. They both had Huntington's chorea. They knew it. They got married. They had 10 kids. How many kids had Huntington's chorea? How many should have it? How many should have it? Not 10. Remember, it's autosomal dominant. So one has it, one doesn't, right? All you need is one. Right? If you've got the disease, you've got the Huntington's gene, and one of your genes doesn't have it, right? And there's your spouse, and they have the same problem, and you're going to have basically anybody who gets a Huntington's is going to get the disorder, but there's going to be 25% of the kids who are not going to get it. They're going to be absent. So actually, the correct number is 7.5. Right, just if you had a big population, it'd be 75%. And that particular family had 8 kids, with 8 people with eventually Huntington's. So genetic counseling is beyond important with this, because if you get this gene, you are in serious trouble. Eventually, dementia, global cognitive impairments. If you go up to Sonoma State, where there's a lot of end-stage severe neurodegenerative disorders, there's a whole ward or two just filled with end-stage, very severe, sadly, Huntington's patients. So let me show you a couple of movies to give you a feel for this. This is a patient I saw over in Merrithew, and he was one of a family where multiple kids had Huntington's.
Turn around and walk back again. Okay, walk back.
Whoops, what'd I do? You can see the twitching there. There. Arms going. He's got axial. His body's jerking. His limbs are jerking. His fingers are jerking. He has choreiform jerks everywhere. Now you can see a picture just like that if he was a Parkinson patient who was over-medicated, right? He'd look the same, but this is not an over-medicated Parkinson patient. This is a genetic disorder, Huntington's disease. Here's another case that I just saw. So if you could let your arms go loose, and if you could just walk back to the woman right at the end there. Just do that for me, sir. So he has, turn around, sir. Excellent. Come on back. He's got what's called appendicular choreiform movements. He has a lot of movements in his fingers. And I'm sure he has them in his toes. Do your toes jerk also?
Yes.
Yeah. And he also has axial chorea. If you can go back in time, and maybe you can't, but when did you first start noticing any kind of twitches anywhere? How many years?
Maybe 2 years.
Nothing
maybe 2.5.
2.5 years. Okay. All right. And where did you first notice them?
In my hands.
Do you feel your throat spasming on you?
No.
This is what usually kills people.
Sometimes I can't swallow.
You can't swallow. Can you try to do
Chorea
something
in
for
the
me?
oral
Let me see if you can
pharyngeal
hold
area,
the
they
note for
aspirate.
me. Can you do this? Go.
Watch, he's going to get a jerk.
You hear that? That was a choreiform jerk in his oral pharyngeal area. Okay, do it again. See, he's having oral pharyngeal chorea. Let me just feel you here, sir.
The tone in these patients
almost
is
all
absolutely
patients
loose.
with Huntington's
Just
chorea
the
is
opposite of the
extremely
patient
loose.
with Parkinson's.
And there's no cogwheeling like you would see in someone with Parkinson's at all. Can you walk the line for me? Can you try? I know that's not the easiest thing.
You actually can
Real
still
tight,
walk
tight,
the line. His
tight.
cerebellar
Yeah,
function
tight.
is relative.
And he has amazingly good, considering the amount of chorea he has, he can...
Pretty
he
amazing.
doesn't
So it's
have
not a
any
cerebellar
cerebellar
problem, right? He's walking the line, but he's got
You're doing
generalized
great.
chorea.
3 words.
We'll go through the rest
Football.
of this patient's exam.
when we do the executive part of the course, because he really shows classic frontal lobe problems because what happens is not only do you lose your caudate nucleus, which is inhibitory to your motor system, you lose the projections of the caudate to the frontal lobe, and you become cognitively very, very impaired. The disease, really, if you look at this shows it very nicely. Here's your normal caudate nucleus pushing in on your ventricles in this very nice coronal cut right here. There's your big old corpus callosum. Huntington's disease, pretty simple. Your caudate's almost gone. It's just a sliver here. This is all caudate here. And this is all caudate here. And you can see there's just a sliver of caudate remaining here. Mammillary bodies look pretty good for memory. So that's the classic brain of Huntington's disease. Autosomal dominant, short arm of chromosome 4. It was discovered in 1983 in a town in Venezuela where they had massive numbers of people with Huntington's who were basically getting married to each other. So they had this massive genetic tree that they could get data from, get blood from, and they actually isolated the gene to the short arm of chromosome 4. And basically there's these trinucleotide repeats for those of you who do molecular biology type stuff. And the number of the repeats outside of the normal range predicts just how early on and how severe your Huntington's chorea is going to be. You have to be very careful with this disease when you tell somebody. By the way, the first thing you see, when I'm trying to see, there's a family history of Huntington's. The question is, does this person have Huntington's? I have them lay out in the hospital bed, and I just look at their toes and hands. If they do this, see what I just did? You see that? That's Huntington's. That's early stage. It's those end stage is for anybody. This is how they really present. Little jerks in their toes or their fingers. You have to be really careful because the patients have seen their family members die, and they often die from aspiration because you just saw this gentleman there when he was trying to hold a note, and they have trouble swallowing. It's not a pleasant disease, and it is probably got the highest incidence when you learn you have the gene and you're going to get it. Probably the highest incidence of suicide in any neurological disease. You need to be really careful on how you interact with the patients with this particular problem. And that's just the trinucleotide repeats for the MCB people who want to play around with that. This is not a molecular biology course, but you do need to know a little bit if you're going to take care of people. So I think we did a nice overview of too little and too much movement. And we covered the big ones. Parkinson's, by far the biggest. Then the less common one, Huntington's disease. So I think we've got enough there. I think what's our next one on? What do we do next? Can't remember. I'm losing it. Anyway, what? Tumors? Brain tumors? Okay, I'll upload the slides tonight. Thank you. Yes, sir.
Know the circuitry of the direct and indirect pathways?
No, that's too much. I just wanted to know they exist.
I kind of figured.
I wanted to know. I don't know what I'm going to put. I think I'm going to write the exam questions up there, just to torture everybody.
What's the
only problem is it would mean that you guys.